Hello and welcome back to Behind the Headlines. I'm Marty Radovanic. This is part two, the first two-parter that we've done since we launched this program with a gentleman who I said in the first episode I have long admired. Great respect for this guy, Dr. Zane Gates, an Altoona physician who's not like any doctor I've ever met in one respect. My personal physician and Dr. Gates, I think, would get along well because both of them are more concerned really about treating the patient than about anything else. But we started talking about how we treat people in this country. And I want to go back to where we left off, and then I have some other areas to get into. But I want to talk more about Gloria Gates Care. You started to tell us how you've laid out, you basically have created a new way of not only providing health care, but paying for it, because that's the big, that's the 8,000-pound gorilla in the middle of the room, right?
Yep.
How do you pay for it?
Yep.
So let's go back and review. You kind of told us that it's a completely new model. I did ask you in between the tapings here. There's nobody else doing this
Nobody else in the country. There's people doing something called direct pay primary care, but it's only primary care. And primary care is cheap. It is. I mean, $75 a visit. I mean, to some people, but for the most part, that isn't what gets you. It's the MRIs, it's the labs,
sure,
it's the CAT scans. And when you combine all those together, because I designed this whole model after the computer industry, after Apple, and how they did in jobs and Moore's law. What I did is by bringing all these things together, the more people you get involved in it, it gets cheaper and cheaper and cheaper. So what we actually do is we actually make the cost of an MRI go down. We make the cost of the labs go down.
How?
Because you make it a fixed cost, just like a computer. Problem with healthcare is when we come up with something that's really good, right? It starts out expensive and stays expensive. It never gets cheaper. It never scales. But think about television sets and computers. Right now, we're still, with cancer, we're still using something called cyclophosphamide, and it's a derivative of mustard gas. We've been using it for the last 40 years. The tech industry is talking about artificial intelligence, nuclear fusion reactors. We don't have the ability to stack innovation on top of innovation, because when we have something good, it starts out expensive and never gets cheaper. When tech, think about that cell phone you have in your hand.
Right.
In the 60s would blow people's minds away.
Sure.
You know what I mean? And it's under $1,000. You can get them for $200. Think about TV, how its prices come down.
Yeah.
Is because they fix the cost. That's what we're doing. We're taking all these things, and it's no longer episodic. It's no like the system gets paid by a membership, just like Netflix and all these things like that. And you necessarily don't have to have your MRI churn out as many patients as you possibly can. You don't have to churn out as many, I need to see 100 people a day so I can make. No, now you can spend the time with the people. You have all these other resources. We completely reconfigured the system in a new economic model that scales. Our costs go down and down and down, the more membership. And we can then add more services for folks. And then we can treat the poorest of the poor and the richest of the rich. The people, we have CEOs of corporations around here that we see, and they get the exact same care as the homeless guy. That's equity. And when you build an economic model like we have, it's no different. A Medicaid patient to us is no different than a regular Geisinger patient. There's no difference. And that's everybody that comes into our place is the same. It's all the same payments, all the same everything.
How many people work at? Is it called Gloria Gates Care?
Gloria Gates Care.
Okay,
yeah.
so it's in a building. I mean, it's
But we have a place here and we have a place up in Berwick, Pennsylvania as well.
All right. So how many doctors work for you?
We have 3 doctors, and we have 9 nurse practitioners and physician assistants.
Okay. How do you pay those people?
Well, what we usually do is there's something called like a direct deposit. So,
okay. Yeah, I deserve that. I deserve that. Yeah, you hand out with little.
The insurance company and soon companies pay us a membership fee. That's
Right.
not outrageous. It's $150 a month
Per
and
person.
per person.
And what do you get for $150 a month?
Concierge style primary care that gives you access to a dietitian, a pharmacist, and for everybody gets a health advocate. And that's really important, especially for poorer folks, because something called social determinants of health are just as important as caring for people, making sure people have housing and making sure that they have food safety and all these things. The advocate also helps you navigate the system. That also includes all your radiology, MRIs, CAT scans, all your cardiology testing, all your pulmonary testing, all your labs, all your outpatient psych, all your durable medical equipment. We also have something called ERISA MD, and that makes us avoid 70% specialist visits, because a lot of times it's just communicating with the specialist. And when someone just has like, hey, I have my thyroid's off, instead of sending you to a specialist, we can treat all that kind of stuff. And there's no copays and no deductibles for any of those services. We even for people with lower income, we provide transportation as well.
How many people are in your census?
Probably now about 6,300 come September. Right now, 5,400, and then in September we just added we work with some doctors too that have our kind of patients that we cover, like independent doctors, and we convert their patients to our model.
So I have to, it's interesting. You say you work with the Geisinger and UPMC, so it's not like the big guys, because those are two of the biggest, would fight against you. They've decided to work with you?
They work just with us. Because what we do is we help save them money, because people are being well cared for. So it's a lower risk, and all the services we have are a fixed cost for them. There's no risk in it. They're taking all that out and carving it out of the insurance formula, right? So now they only have to cover 15% of what may happen. We're taking 85% that may happen, and we're removing it. So now it looks more like real insurance, like car insurance, health insurance.
Right.
And this has been evident by the National Academy of Insurance Actuaries. They came out with this issue brief in 2008 because they were like, hey, well, you're expanding all this insurance. We're here to say that it's mathematically doesn't fit. They clearly said that the two most important variables in the insurance formula, health insurance doesn't fit, so it's doomed to fail. And that's coming from the National Association of Academy. You just cannot continue to put all the stuff that you know that's going to happen. Like you're going to need a checkup,
right,
a couple times a year. You're going to need a stress test.
Right.
Why are we putting that at a risk? That shouldn't be a maybe. That's going to be 100%. That doesn't fit in a risk formula.
No.
It's better to take that and pay directly for it, because you're going to use it. I mean, you don't have your water's not running at home, right? But you're still paying a water bill every month, right?
Yeah, whether you're using it or not. Yeah.
Yeah. So it becomes astronomically cheaper.
Let me ask you this then. When I told you I have lymphoma, I was diagnosed in 2014, saw a guy in Pittsburgh at the
Hillman.
Yeah, at Hillman.
Yeah.
And my oncologist in Johnstown sent me to him, because my oncologist in Johnstown, when they looked at it, he said, we're not going to treat you with chemo. And my wife freaked out. Like, what does that mean? Is he not going to be around? And he goes, all right, you're going to go down and talk to this guy in Pittsburgh. And he spent an hour and a half with us. And they put me on a drug called Rituxan. You don't need chemo. We're going to be, that's
a great drug.
It was for me, but it's a blood cancer, which means, and the first thing he said to me was, well, I need to tell you, you're never going to be cancer free. You're never going to be cured. And I looked at him and I said, you made me drive two hours to Oakland in the middle of the afternoon. I can't wait for the ride home. To tell me that, you could have told me that over the phone. And he laughed and he said, well, I want you to understand. And it took them about 6 weeks to identify the type of lymphoma. I have non-Hodgkin's marginal zone, but it will be with me the rest of my life. So I see my oncologist on a regular basis. I get blood work on a regular basis. And every year or two, my oncologist orders a PET scan. Let's just make sure that there's nothing else going on that we can't see. When it first diagnosed, had like a golf ball lump in my neck that I didn't realize was there. But anyway, then he taught. But I remember when I went on Medicaid or Medicare, and I'm on Medicare, and we have private insurance too. And he said, well, the thing about Medicare is that it will only pay for 3 PET scans for the rest of your life. And I remember looking at him, yeah, that's the reg. And I looked at him and I said, well, that doesn't fit my profile very well. And he goes, yeah, don't worry about it. We'll figure a way, around it. But my point is, when they told me that and I looked into it, yeah, it's true because of, and I thought, no, wait a minute. I have an identifiable disease, clearly identifiable. You know what it is. You know how it operates. You know what it can do. As I tell people all the time, I have never allowed it to define me. It never will. It may win in the end because that's what cancer does, but it's not going to define me. All right. But still, you know the risk I have. And even this government program, Medicare, won't pay for it because it's so expensive. There's something wrong there.
It's sad because
I'm somebody, I need that scan every 2 years.
Right. And
and I always think about this, if they find it again and they wouldn't pay for it because insurance said we're not going to pay for it. Now what it's going to cost you guys to keep me alive is going to be a lot more than if you paid for the scan, right?
Makes no sense whatsoever. And that's what I mean. That's why our model takes, and we'll have PET scanners and all that stuff. I hate to tell you this. Stuff isn't that expensive. I'm trying to tell you.
Yeah, I get it.
You buy it once and then you're done and then you use it. And it's more like, again, you might have a fancy treadmill at a gym, right?
Right.
But everybody doesn't need to be on it to make economic sense.
Right.
That's what this model is. Think of it like a gym. You can have a fancy, beautiful treadmill, but everybody doesn't need to use it. In our current model, if you buy that fancy treadmill, everybody needs to use it.
Yeah.
And that's why Medicare and these insurance companies come back and go, we can only have 3 because of it's a mathematical problem.
All right, let's get to the elephant in the middle of the room. There's all this talk about Medicaid, which is clearly insurance for poor people.
Yes.
No sense trying to hide. That's what it is.
Low income.
Okay, but to point so that you understand, this isn't for everybody.
No.
And there's this consternation, and we have a new bill, a budget bill that passed in Washington that is going to eliminate X amount of hundreds of millions of dollars from that program. And they insist the people who favored it say will not have any impact on the people it's designed to help. That just makes no sense.
It's not. And it's just all politics.
Without
which
going
I
through
just stay. Yeah, I stay out of politics.
Yeah, I don't want to talk about the political
but
stuff.
I will tell you that it's a really bad idea. And here's the reason why. You're messing with something that's already very fragile, right?
Yeah.
And now, not only are you cutting and pushing people off of Medicaid and you pushing them to the exchanges, right? You just go to the Affordable Care Act. Now you took away the additional subsidies to the Affordable Care Act. So now you're going to suddenly undo, even though the Affordable Care Act's far from perfect, but the one thing it did was get a lot of people covered.
Yeah, that was the thing when it was talked about. And even those that thought it was a bad idea had to admit it's covering people that weren't being covered before, which was the entire intent. And again, I appreciate, you try to separate the politics from it.
That's what makes it wrong, because once you put politics in it, it becomes one side or the other.
What's the typical Medicaid patient? You know them very well.
Your typical Medicaid patient is somebody that works in a small business. Like if you go here to like Fee-Fi's, the little convenience store.
Right.
Or you go up to Johnstown and you see this guy with this small lawn care.
Mom and pop
stores, which is
backbone of this country.
Which is 51%
yeah,
of
I was just going to say.
in this country.
Right.
That's the face of it. The rest of it is, the mentally, the mentally, people with really bad mental illness, people who have been born with really bad birth defects like cystic fibrosis and Down syndrome and stuff like that, and children, and that's Medicaid. But 92% of the population work, and that should, if anybody's from any side of any political party, and anybody could say that that's not what the program was intended for. Mm-hmm. The program started out back when it was at a different time. These people back then, right, are the people we're talking about now. You know, most people back then worked and these things like that. This was just even before the beginning of welfare. So you can't compare it to what it was intended to do.
Right.
The intention was to give people care who won't get care. That's the intention of that. And people twist it to make it sound so that we can move money around for other things. But it's a big mistake. I don't care if you're Republican, Democrat. At this time, if you understand healthcare and understand how fragile it is, you're not. It's a Rubik's cube. You know, it's not in a bubble. Like, well, we can just mess with Medicaid and nothing else is going to be affected.
Yeah.
Everybody else's premiums all along, from big businesses, people who have good coverage. What do you think hospitals are going to do when they lose all that care? Right?
They got to make it up.
They got to
somewhere.
make it up somewhere.
Yeah.
So people just, you're not saving any money doing this.
Well, and the point of this particular provision of that bill was this doesn't even kick in. Like, people are saying, well, look, we did it. There's been no. Well, that's because it's scheduled.
2027.
Right. It doesn't even begin to take effect until 2027. So it's kind of like, again, taking the politics out of it, but, well, I can do this now because it's not really going to impact, and I'm going to get reelected next year, and then I'll worry about, because that's just the honest truth of what's going on. So in 2027, give me your assessment. You're a doctor. You're involved in care for people. You've designed a health care plan that separates. I mean, it says this is for everybody. We don't care where you come from, what you do. This is for everybody. So what happens in 2027?
2027, it'll make everybody's insurance rates go through the roof. You're going to have a lot of people that are uncovered that are eligible, because if anybody ever went and applied and went through the Medicaid system, which I challenge anybody to do, that's for the bill, for that particular part of the bill.
Right, that part of it.
Yeah, to try. It's very difficult. So if you don't check one box, you get kicked out. So a lot of people that will be eligible are going to get kicked off. And you're going to see a lot of, they have this fund for hospitals, small hospital. It's not going to be enough. The Medicaid doesn't pay that well as it starts. And now you're kicking all these people off.
So what happens to those people?
Well, if they have chronic diseases, they die. That's
if
what
they
happens.
have cancer, and
if they have cancer and they can't work, they'll get Medicaid.
Right.
But if they have something, say you have MS,
Okay.
or say
All
you
right.
have, you're still functional, but you need $1,000 a month medicine, you're not getting it. If you get on the exchange, there's exchange rates, you know, like Obamacare.
Right.
Those rates are going to go up by 75%. So the people that are going to get hurt the most are the working poor and the middle class. They're going to get slaughtered by this. And people do not understand it, because most people who vote on these bills don't understand healthcare. Most people don't understand healthcare.
No,
I didn't understand healthcare until I was forced to understand healthcare, because fueled by a passion to help, you have to understand what's in the box first to be able to think outside of it. You know, all these people run around doing stuff outside the box,
Right.
but they don't understand what's inside the box. And that means you have to understand the fundamentals of insurance. And I can tell you, it's going to be hard on insurance companies, because all the healthy people are going to go off Medicaid. So now you're going to be left with the sick people. So their risk is going to go up. So it's a really bad thing that's not, it's going to affect everybody. Everybody. No one's going to have Cadillac benefits anymore. It's just because the system is interlinked. That's the problem. They try to think of it in silos, and healthcare is not siloed. It all interacts with each other. It's a Rubik's Cube. If you turn it one way, it affects the other side of the box. You know, there's no free lunch in this business. That's why in our model, we make everybody the same, because right now you're treating people differently based off your insurance. Well, that's crazy. When I was studying for my medical boards, it doesn't go, oh, well, you can treat this person different than we tell you to do it.
Yeah. You're scaring me. And I tell people this all the time. I go, okay, I'm 73. I've got enough chronic illness inside of my body and bones. As I always say, it's taught since I was a young kid about, Yeah, God will only give you the cross you can bear. And I always say, well, if I ever get face to face, and I'm not so sure that's going to happen, I don't think I qualify. But whatever, if I get face to face, I'm going to talk to him about that because you gave me a lot. You could have spread it around to other people. But so I'm not going to live. I don't think I'm going to live another 20 years. I mean, I might, but I'm not worried about it. I'll figure out a way because but I worry. I've got my oldest grandson is 21. My youngest is 15.
Yep, that's what I'm.
That's who I think about.
Yeah.
And what's going to happen to them when they're in that position where they're going to be able to keep their family together? They're going to have health care. Even if you never use it, you got to have it, right?
Right. And
so what happens?
I hope that my model spreads because it really, really, we've proven that our per member per month cost goes significantly down the more people we have in it. It doesn't happen in any other system. So more things like that I'm thinking like is what's going to help because the insurance model's dying. It's a math problem.
Yeah. Well, okay, let's say somebody's watching this and they're a CEO or they're a general manager or they're somebody who's in a supervisory role at a company and they said, I'd like to go to my HR person and I'd like them to investigate this. What do they do?
They can call us. I don't have my number, but they can call us at Gloria Gates Care and we will lead them. I work with a guy named Donnie Beaver. He's my business partner, and he handles more of the sales part of it. And we'll get them covered. If someone doesn't have coverage, they can call us, and we have many different options to help them.
You're just one small provider. I don't even know what to call you, but I don't understand. I guess the biggies don't want people like you to be successful. Is that fair?
The biggies want to collaborate.
Yeah, because they're going to have to.
They're
because
gonna
their
have to.
business model that's existed for decades isn't going to exist anymore.
It's not going to exist. You're going to start to see, again, it's a math problem. If someone lays out the math and understands insurance and understands how the rates, game over. If health insurance costs more than the average family income, it's a game over. It's game over. Nobody's going to be able to afford it. I mean, it's the facts. And people try the old regime, and no offense, but most of the guys that are running healthcare companies now are in their 60s and they're like looking, that's going to be somebody else's problem.
Of course.
So that's why you're not seeing as much change as you should. But very soon when they start seeing their bottom lines go down, and they are going to, because the risk is going to get worse and worse and worse, it won't make sense for someone healthy to buy it.
It's not. A lot of people tell you healthcare in this country is broken. It's been broken for a while.
Yeah.
Do you think will this be? Does this have the potential to push? We do fall over the cliff. We're standing at the edge of the precipice now. But if a few people start falling, the people out front,
Yep.
Is that going to, you think, change the way
Yes.
we look at it? It almost has to.
It has to. Once you start moving people's cheese, you ever say a book move? That's what's going to happen. And I think the big beautiful bill, the one thing it'll do is push us off the cliff. If you lose this many people and we create this many uninsured people, it'll push us off the cliff. And everybody says, "Oh, you're alarmist." I am not political. I'm into people ticks. I don't care what side of the fence you are. I'm rooting for everybody. That's what we should be doing. I'm rooting for our political leaders to be successful.
Sure.
I don't care where they're Republican or Democrat. I don't care about that stuff. But I can tell you this, and I mean it emphatically. What has happened is a bad thing. And there's no sugarcoating it. And anybody who works in this business like I do would 100% agree with me.
Will there be other Zane Gates coming behind you, people who care more about treating the patient than how they get paid to treat that patient?
I hope that, from my mother's love, that I can set this example to inspire other people to do what I'm doing. A ton of doctors want to do what I'm doing. We just got to get us all together. In the end, we're the ones that took the oath, and I take it very seriously. And I know most of my people physicians and nurses and pharmacists we work with all agree and think like I do. We just have to have the playing field to set up so we can go and help people.
I think Gloria Gates would be very proud of you, sir.
She was tough. She'd be proud, but she'd never let me know.
Yeah. Dr. Zane Gates, a pleasure to talk to you. And I hope people wake up.
Yep.
I think they're going to be forced to, but thanks so much and good luck as you progress. And thank you for doing what you're doing.
Yep. Thank you for having me.
It was a pleasure. And we'll see you next time.
All right.